All right, you're in the heart team meeting. Patient is stable, but they've got multivessel coronary disease. You have two options on the table, PCI or CABG. But only one is going to give them the best shot at long-term survival. The clock is ticking. The decision is yours, stent or surgery.
Look, in this situation, you don't have to guess. There's a simple, powerful rule that just cuts right through all the complexity. It's this: if you see D, L, or 3, you call the surgeon. It's that simple.
First up, D. D is for diabetics. This is a critical patient group, a total game changer in your decision-making.
Next, L. L stands for significant left main coronary artery disease. We're talking a blockage of more than 50% in that absolutely crucial vessel. And finally, 3. This means you've got significant disease in 3 different coronary vessels. Got it? DL3. These are your absolute must-call indications for surgery.
Now, a brief pause. This content is for educational purposes only and is not medical advice. It is not a substitute for clinical judgment or official medical guidelines. Always consult the latest guidelines and your specialist physicians when making patient care decisions.
So let's really break down these 2 paths for revascularization, getting blood flow back to the heart. On one side, you've got PCI, percutaneous coronary intervention, which is basically getting a stent. And on the other, you've got CABG, coronary artery bypass grafting. Yep, the full-on surgery.
The best way to think about this is like this. A stent, or PCI, that's your spot fix. It's an incredible piece of tech designed to prop open one specific narrow blockage. Bypass surgery, or CABG, well, that's the detour. We're not even trying to fix the blockage. We're building a brand new highway for blood to flow around the entire traffic jam of a diseased artery.
So let's circle back to our rule. D for diabetics. This is a really important one. Why does this specific group of patients get a different recommendation? Well, the answer, as always, is in the data.
And the evidence is just definitive.
For patients with diabetes, surgery gives them a proven survival benefit. The landmark FREEDOM trial showed pretty clearly that CABG is superior to PCI for diabetics who have multivessel disease. And you might ask why. Well, it's because diabetic patients often have these long, spread-out sections of disease, which makes that spot fix from a stent a lot less effective in the long run. The surgical detour is just a much more durable, lasting solution for them. But okay, let's flip the script. We've been talking about stable disease, but what about a full-blown emergency? I'm talking about a STEMI, a massive heart attack. In that scenario, the entire equation changes. Here, your number one enemy is time. Speed is everything.
This is the critical door-to-balloon timeline. From the second a STEMI patient hits the hospital doors, that clock starts ticking. The goal is to get that blocked artery opened up with a balloon and a stent in under 90 minutes. Now, if the hospital doesn't have a cath lab to do this, the goal is to get them transferred and get that artery open within 120 minutes. You have to understand, every single minute of delay means more heart muscle is dying, permanently.
So we see it, right? PCI is the champion of speed in an emergency. But for those DL3 patients who need that lasting solution, what makes the surgery so good? What's the secret sauce? A huge part of the answer lies in the type of graft that's used for the bypass.
The absolute gold standard is the LIMA, the left internal memory artery. Now, this isn't just some vein we borrow from the leg. No, this is a living, breathing artery that's harvested from the inside of the chest wall. And because it's an artery, it's naturally built to withstand pressure and resist developing new blockages. It is just a far superior pipe to use for a bypass.
And the numbers on this are just remarkable. A LIMA graft has a 10-year patency rate, that means it's still open and working perfectly a full decade later, of over 90%. I mean, think about that. That's incredible durability, and it's the real reason why surgery is the more lasting fix in these specific cases.
Okay, we have gone through the evidence, the mechanics, the whole shebang. Now it's time to lock in those core surgical indications. We're going to burn it into your memory with the DL3 chant. Say it with me.
D for diabetics. L for left main.
3 for 3 vessel. And what's the ultimate takeaway here? It's simple. PCI is fast, CABG is lasting. That's the core principle you need to remember.
So, I've got a question for all of you out there in the field. Which environment do you find more compelling?
Is it the methodical, focused precision of the operating room during a Lima harvest for a CABG? Or is it that fast-paced, high-tech, beat-the-clock atmosphere of the cath lab during an emergency PCI? Let me know your thoughts.
But hey, here's one last thing to leave you with. We've spent all this time talking about how to fix the plumbing, right? How to restore that precious blood flow. But what happens after? The heart attack still happened. The heart muscle is still scarred. And believe me, that damage creates a whole new world of problems. Join us next time as we dive into what happens after the pipes are fixed.